So I'm going to talk about infants. When I say infants, I mean under 6 months of age or maybe up to a year. So why it is different, like considering a 2 year versus 1 year also, there is a lot of difference between children who are say under 1 year of age compared to those who are little older than 1 year. Even that makes a whole lot of difference because the etiology is different. Children who are presenting earlier than 1 year probably are likely to have more chances of related to intrauterine infections, especially in our country. They are more likely to be associated with ocular and systemic comorbidities, which are inherited or sometimes isolated. And anatomically, it is a little bit more challenging to do it in an under-year child compared to somebody who is 2 or 3 years old. So questions when you face with infantile cataracts is surgery, when, if investigations, what are the required, and these are the usual questions what you need to evaluate these children for. So how early is early? Because early surgery increases the risk of glaucoma. That has been proved in large number of studies. But this risk has to be weighed against the risk of developing deprivational amblyopia if you wait too long. So these two papers, one by Birch and another by Lambert et al., recommend surgery by 6 to 8 weeks. And this probably is just the right age where you can, in a bilateral visually significant cataracts, probably you should intervene. Of course, these recommendations may have to be modified by child's fitness for anesthesia, especially a lot of our children who have intrauterine diseases can also have coexisting cardiac and lung issues and may not be fit for anesthesia as early as 6 or 8 weeks of age, or sometimes may not even present by that age. So this is to be guided by your pediatrician and anesthetist about the fitness for the surgery. Preoperative evaluation, I always believe that surgery should be used as an opportunity to do good evaluation under anesthesia, and this opportunity should be taken by everyone. You document corneal diameter, axial length, IOP, keratometry, and if possible, gonioscopy. And of course, if you're planning an IOL, a biometry has to be part of it. And this must be done because this baseline evaluation will have some value when you follow these children for next 10 years or 20 years or more. So surgery, luckily there are, in infants, most of the surgery can be done through side ports. That's one. So that allows us to have a closed chamber and a knot. And you really need to open the main entry only to put the IOL should you are giving. Small tips here, MVR blade is better than your side entry knife because it keeps the chamber formed, and with the newer machines and 23 gauge vitrectomy, MVR blade entry is good enough. Capsule is elastic, but be prepared for occasional surprises in terms of really fibrous capsule even in infants. Similarly, occasionally there can be a very dense calcified nucleus even in a 6-month-old baby, so this must be kept in mind. And if you are planning an IOL, it is imperative that you should have a good cohesive OBD with you, and which flattens the capsule and keeps you comfortable when you are doing the rexis. I don't need to overemphasize the importance or how much life has been easier with availability of trypan blue, because none of the children, even those who don't have total cataracts, often don't have a good red glow to go with. So I think life with trypan blue has improved significantly for the surgeons and for children also. So again, when you're coming to posterior capsular, there is another speaker who is going to talk about posterior capsular dehiscence and probably another, but you have to be prepared that these can complicate your posterior capsular opacity, complicate your posterior capsular posterior capsulotomy. So which child you will put the IOL, obviously it's an anatomical decision, as I said earlier. It has nothing to do. So this baby who are both 6-month-old, this with a 9.5 corneal, 8.5 to 9 corneal diameter, I'm not going to put the IOL. So here the decision is easy. As you can see, a dense nuclear cataract, which is very typical of rubella, and a small cornea. And you can do very comfortably the entire surgery using a 2-instrument and a small port, compared to another 6-month-old who probably is, as you can see, nice large eye, well, good dilatation, And here probably as this 7-month-old child, you need not hold on the IOL, and you can again very comfortably do the surgery. Almost entire surgery can be done through the side port, giving you advantage of a closed chamber. And maybe just before starting vitrectomy, probably you need to open the main tunnel to allow you to put an IOL in the bag. So I always do capsulotomy and vitrectomy before putting IOL. So after that, it's like a regular surgery, and nothing really new about it. But as you can see, the ease of manipulation is so much more, even though both the children are 7 months old, the decision making can be different. Again, this is another child where I was just mentioning. You can have a really dense nucleus. As you can see, this is a 4-month-old child, and I am not able to aspirate it. I actually would have liked to have a phaco probe with me here to aspirate it, but since we were not planning to put an IOL in this child, it took me with a serious risk of that bit going down behind, because in the whole process, I have actually made a small posterior capsular rent also while trying to use that. So you might have to be prepared for a really dense nucleus even in a very, very young baby. And the lesson here is that do not open the posterior capsule before that. Try as far as possible. And maybe if it is really calcific, instead of struggling, just make a 2cc incision, 2 millimeter incision with and put a probably use your post episcleral epi nucleus settings to aspirate it. Far more easier. Life is really easy. Then sometimes you can have really looks like a non-dilating pupil, and very commonly in infants you can get these really dense vascularized membranes which are stuck pupil. No question of IOL here, because you can see the amount of struggle which will be required for this patient. And as you dilate the pupil and stretch the pupil, you can see elongated ciliary processes which are very, very typical of posterior PHPV. And despite my stretching the pupil, pupil is not dilating. So I finally have to go with a vitrector to do a little bit of pupilloplasty to allow me to do the surgery comfortably. And as you can see, it's a dense vascularized membrane on the thing, and you probably have to use a 23 gauge cautery to open and vascularize the vascularized membrane, which needs to be cauterized so that there is no bleeding. And there is a dense arboreal vessels on the capsule. And after cautery and all, finally we have stopped the bleeding, and you can see another dense membrane behind. But it is very gratifying to these children, because at the end of the surgery you can see already there is a little bit of blood which has trickled back into the vitreous cavity. So these patients can have really vicious bleeding post surgery also, and you have to monitor them for that. This child did well. We put the IOL and his vision is around 1 meter, 3 meters, but without my surgery probably he would have been hand movements. So some ambulatory vision is better than. Now another scenario where you can see, again here it is anticipated that there is probably a posterior capsular, and so one small here you get the rest. As I said here, without trypan blue 10 years 15-20 years back, these surgeries would have been really, really difficult. But here now, thanks to trypan blue, you can actually see where you are going. And you can see a really fibrotic capsule, even though baby is very young. Not necessarily that always the capsule is very elastic. Sometimes you can have this kind of fibrous anterior capsule. And And you can see the nucleus is almost in the anterior vitreous cavity. And the indication where you should suspect is a relatively clear area here, as you can see, and a very dense central nucleus. It almost, you should be always prepared, and it's probably better to go with your vitrectomy probe to aspirate this, because your vitrectomy probe can be used for vitrectomy also, as well as for aspiration. So rest of the process is similar. Again, sometimes this one I will just show this. Sometimes you can have, it looks like a small central cataract with a PHPV like thing, but there is a small opening through which, when we see, you can almost see that it looks like it is actually a tunica vasculosa lentis, and the lens is clear, which is underneath. So membrane is only at the level of iris. So be a little careful going with a vitrectomy instrument and all these in these patients. And probably, as you can see, once we cut that membrane, you can see the lens beneath is almost clear. You don't have to, and very happy outcome in this child, because nothing I needed to do before that. Irrespective of surgery, correction of aphakia is very, very important. Any of these methods can be used. IOLs, there is another speaker with after me who is going to, as Love has mentioned something about IOLs in infants, so I'm not going to go and waste time on this, but basically do what works best in your hands and not really worry about it. A good clean aphakia is better than a complicated pseudophakia. So this
Sorry to interrupt, ma'am, but you may have to wrap up in the next 30 seconds.
30 seconds. So this is, as I said, it's an anatomical decision, and this is my personal take on where I will put IOL in an infant. When I say infant, less than 1 year. So if you don't have availability of other services like glaucoma person, or you cannot check the pressure, probably it's better to leave them aphakic rather than doing it. Follow-up, as I said, this is the most important step. There are several good surgeons, but a lot of people trip up in this step of the surgery, which is the day first onwards for the next 70 years. So surgery is always often the first and the easiest step to do on a very, very long road. These children need long follow-up and need refraction, disc evaluation, dilated fundus evaluation on every visit. And one tip here, that wide angle imaging is very, very useful in these young children. So if you have optos or something, makes your life really, really easy. Thank you for your attention.